I think it's time for us to begin this interesting session with some colleagues who have been working behind the scenes on an amazing tool, which I think is what we're going to get to hear about today. Before we begin, I just want people to introduce themselves. So if I start with yourself, Katerina, would you like to tell the audience who you are and what your impact and your role has been with CARESA?
Yeah, absolutely. Good morning, good afternoon, everyone. My name is Katerina Maslova. I'm coming from AstraZeneca, sitting within our global medical affairs team and responsible for our wider medical sustainability strategy and execution. And in terms of the CARESA work, I've been there since the inception, developing and co-leading the project with colleagues of mine in the company. Great to be here.
Fantastic. Great to have you. And Gregor, what about yourself?
Thanks very much, Matt. Yeah, thanks very much for having me here. My name is Gregor Skeldon. I work for Maverex, which is a market access consultancy, but we've been working in environmental assessment of care pathways for a while now. And I've been involved with the CARESA team for about a year and a half as the product manager, doing project management work, and as the technical support manager as well. So all the techie bits, basically.
Fantastic. And there are some of us who love the techie bits, but for our audience today, we're not necessarily going to get into the absolute nuts and bolts unless we want to. So we've got, we're going to be finished within 55 minutes. We've got an opportunity for people to ask questions as they go. So if you can use the Q&A function. There is also a chat box. So if people want to introduce themselves to each other, then they can certainly do so. Yes, this is being recorded. Yes, people will be able to watch it later on. No, there aren't any slides, so no, there won't be any slide sharing. Yes, there will be an opportunity to interact and to engage. And we're going to cover 5 broad areas about CARESA, about how it's been developed, how it gets used, what has been done so far and what the future might look like, and then how people might be able to make use of it and or get engaged. So I'm going to start with a very simple question. We've used the word CARESA so far. What does CARESA mean? What does it stand for?
Yeah, so I can kick us off. So CARESA stands for Care Pathway Environmental Sustainability Assessment. And so it's a modeling tool to quantify the environmental impact of any care pathway. And then you can also use the modeling tool to intervene in that care pathway. Say if you want to change something, you'll be able to quantify the environmental impact of that change or changes. And it's intended to serve a broad audience in the healthcare sector. So anyone, regardless of which geography they sit in, which patient groups they care for, which environmental impacts they want to look at, CARESA is built with intention of being able to be used by everyone.
That sounds an all-inclusive tool. It's all about patients, it's all about care pathways, and anybody anywhere can make use of it. What were the original thoughts behind CARESA? What was the gap in the system? What was the knowledge that was missing that CARESA helps to fill?
Yeah, it's a great question. So the Sustainable Healthcare Coalition developed their guidance around care pathway environmental impact assessment about 10 years ago. And since then, we've seen more and more studies taking a care pathway approach to quantifying environmental impact of care delivery. And what we mean by that is really looking holistically at how care is delivered, both upstream and downstream. So rather than focus on single components or interaction treatments, but really looking at it broadly. So what is the care pathway from a diagnostic part of the pathway, or from diagnosis to palliative care, whatever it might be, taking that full systems approach. Because what happens unintentionally, if you focus too much down to a single components, you might miss what's happening upstream and downstream of the care pathway. So we've seen that research basically appear more and more, especially in the 5 years. What we've also seen is research demonstrating that if you optimize your care delivery, you improve patient outcomes, but as you improve patient outcomes, you reduce obviously the healthcare resource utilization that is extra. So like admissions to hospitals, ICU, etc., which all carry carbon footprint. So in essence, you end up also reducing your environmental impact. And that makes a lot of sense to a lot of us, but we can quantify it. We can bring that data to our stakeholder discussions and make the case internally. So CARESA was really built to bridge that gap, to allow anyone to be able to generate that level of data, demonstrating that better care delivery can deliver for patients, but it can also deliver on the environmental sustainability objective of the system.
I think for me, so as a background, I was a GP, so a clinician. And I think that it's long been known that the most or the least carbon emitting asthma patient is the one who doesn't have asthma. The least environmentally impactful diabetic is the person who doesn't have diabetes. I think I could make that slightly more nuanced and say a better controlled patient, or a better controlled diabetic or renal patient who has got a less severe disease has got a lower carbon footprint. And I think that one of the things that this tool does is it helps to show that, as we'll see in a little bit, very clearly that if we can control the disease, if we can intervene earlier on in the care pathway, earlier on in the diagnosis, actually there is less need for healthcare because there's less severe disease. I think it's always been frustrating for clinicians to realise that there's diabetics having their legs chopped off, and amputated, when actually had an intervention occurred further upstream, it would have been far better for the patient. And this tool, I think, helps to show some of the environmental benefits as well as the patient benefits of doing so. In terms of the users of CARESA, who do you think is going to make most use of this as a tool?
Yeah, this is an interesting question because CARESA is obviously still in beta testing. So the public launch of the tool is planned for later in the year. Anyone who still wants access to it always can gain access to it at the moment, and we have various health system stakeholders already beta testing it. The intention with beta testing was also trying to figure out, who would want to use it, who would find most benefit of using it. I think where we've landed so far is the clinicians and researchers. They're obviously interested in care pathway design and interested in sustainable healthcare. That would probably lean into a tool like this. We will also see things like greener team or sustainability teams in different hospital health system potentially leveraging a tool like this. But what's come out of discussion with some of the hospitals is also, could this tool almost serve as a glue between the clinicians and the greener teams, bringing together those two aspects of sustainable care, which is the environmental side and the clinical side, and sort of drive the cohesion or the interaction between those, demonstrating how care pathway optimizations also deliver on the sustainability goals that the greener team hold.
I think that understanding who the primary users are is going to be really important. And I'm actually going to ask Ollie if you can put up the poll that I forgot to do at the beginning, which asks what role and what organisation are people part of. So I'm going to spring this on the audience. If you could choose one of the options available to you so we can see what sort of people are here today. We'll give people a few moments. I think, Ollie, you can probably see when the majority of people have answered this. And then we'll ask the second question about what sort of role people are in. So we can see what sort of primary users or what sort of people are interested in it from this call.
I'd say as well, just to expand on what Katarina was saying about the intended user base, is that it is very broad. And certainly in the UK, from even my own sort of anecdotal experience in the healthcare system, you see the appetite for sustainability everywhere. In wards, there's boards up with like the green targets and green projects that are going on at, maybe a fairly discrete level. But there's certainly an appetite for sustainability in healthcare, even if right now it's still sort of germinating and it's maybe still fairly nascent and it's smaller objectives and not necessarily care pathway work. There's a lot of desire there, undoubtedly.
Absolutely agree. Ollie, are you happy to put the second question up about the type of roles that people have? And I think, Gregor, exactly on that sustainability traditionally was seen as an energy and estates and facilities thing, or it was a waste management thing. And I think that along with yourself, Katerina, it's bringing that sustainability and addressing the clinical side of it. This is about, you know, the care that is being delivered.
Yeah, exactly right. And we've seen sort of data around this, I think, both from the NHS and the like public-private partnerships, like Sustainable Market Initiative, demonstrating that, you know, 30 to 40% of our greenhouse gas emissions within healthcare sectors sit within patient delivery settings. So as we're thinking through reaching those net zero ambitions that a lot of systems are setting, we need to think about care delivery, and more broadly from a public health perspective, as we're thinking about sustainable care and aging populations and multimorbidities. You know, we need to think more holistically about how we deliver care in the most sustainable and resilient way. And optimizing for the best outcomes, like you mentioned, Matt, is a really great way to do that.
Absolutely. If people are able to click on what best describes their role within their organisation, that would be really, really helpful. So I think that you're, for me, this is, you know, the advantage of having a tool that looks at care pathways and does that direct link between better care for patients is a greener or more environmentally sustainable is a really useful link for people to have. So we can see that we have got some clinicians, some sustainability staff. I'm always interested, whenever we do polls and put other on, I always then want to know, but what other things fall into other? So if people want to pop that in the chat, that would be really, really helpful as well. So if we've got a user, whether it be a sustainability staff or a clinician, what would a successful journey through CARESA look like? And I think, Gregor, you've got a worked example, or you can give us a live demonstration of what the tool could look like and what a user could see or could make use of. Are you happy to give us a demonstration?
Yeah, no problem. I'll share my screen just now so we can go through this. To be clear, this will be quite top line, just because there isn't enough time to go in depth. To go in depth to all the features, it usually takes about 45 minutes just by itself. But let me talk you through it here. So if I can just confirm that you can see the screen. Okay.
Yeah, looks good to me.
Okay, excellent. So it's a browser-based tool, and this demonstration model that I've put together is for chronic kidney disease across various stages from 1 to 5, and then multiple treatment modalities in stage 5 as well. So I'm going to take you through how we build it up in the model from various points. I'm going to try and be as descriptive as I can, because I know not everyone will necessarily be watching, some might just be listening. And this data is largely based on real world studies, but it's been slightly edited for simplicity. So it's hypothetical data, but it's sort of based on real data. So the first part of the model is to look and define your environmental inputs. You need environmental data in order to do an environmental sustainability assessment model, obviously. But the type of environmental data we're looking for is data for healthcare activities. So we're looking at care pathways, right? That's our focus. We're looking at care pathways in chronic kidney disease. To deliver a care pathway, you need to deliver various points of interaction or activities with the health system and with the patient in order to do so. So the first example here, you might see straight away, the first box is at-home hemodialysis. Hemodialysis, obviously a key part of stage 5 kidney care. But there's other things in here, such as just patient travel, refrigeration, and so on. So these are the building blocks that you need to define in order to build up your care pathway for your model. And these activities and interactions, as we said, can be anything. So it's flexible. This is a kidney example, but you could do it in any indication that you're interested in, and indeed in any geography as well. So if we very quickly look at what this data looks like under the hood, because it's going to get too complex and too big a rabbit hole straight away. If we look at the hemodialysis one, for example, you can see here that it gives you the name, the unit of measurement, which is per session of hemodialysis, and then it gives you the emissions for that. So what is the environmental impact of this? And the measurements in CARESA are kilograms CO2, kilograms of waste, and liters of water. And then you have the reference, of course. So as I'll show you in a second, all the publicly available data in CARESA has references. So you as a user can go and investigate this and investigate the methodology and decide if this is what you want to use. But you'll see as well that, of course, hemodialysis or many other healthcare activities as well are fairly complex events in themselves, and they're composed of multiple things, especially when you think of it from an environmental point of view. So for hemodialysis, you need to consider the electricity mix, the machine itself, solid waste, water waste, and so on. So these are all submodules. This is all the components of that activity. If you think of something like surgery, then you need to include the staff being present for the surgery. You need to include the medicinal gases available, all the consumables, the heating and lighting, and so on. And so all these are added together to give you the total carbon cost, in this case, of an at-home hemodialysis. Then for this, we've got fairly familiar sounding healthcare activities for our model. So dialysis, vascular access surgery, we've got transplant, we've got hospitalization. On the next page, we've got things like GP visits, ER visits, ICU, and specialist visits as well. So first step is, okay, well, what's my care pathway and what do I need to deliver that care pathway? Then you need to get your data to get those building blocks, basically. Well, most people don't have environmental data for their healthcare activities just laying about. It's fairly uncommon data. What is available in CARESA is the public library. So if you scroll down slightly, you'll see this environmental inputs library here. All the gray boxes here is publicly available data. So it's publicly available environmental data for healthcare activities and travel. So you can use any of these as soon as you log into CARESA. You can take any of these and put them into your model and start playing around straight away. And you can search and filter by country or the study and so on. And there's about 250 publicly available data points right now. That is growing over time as more data is generated and we find more. But that's what's available to anyone as soon as they log in. So once I've defined the building blocks, Matt, the next thing that I want to do is add them together.
And now I'm going to define the care pathway, right? So I'm going to move on to the next part of the workflow here along the top, which is the care pathways. And as I mentioned in this case, they're for CKD, so it's stage 1, 2, 3, 4, and then stage 5 with all the various treatment modalities for 5. So now we're building up, okay, what do we require for stage 1? What's required to deliver the care pathway for stage 1 CKD? So if I click on that, the stage 1 here, I can give you an idea of how that's built. We've basically added in all the relevant activities from the previous step that we've defined into this care pathway. So what I'm saying is for stage 1, you need patient travel, you need ICU visits, you need GP visits, ER visits, specialists, and hospitalization visits as well. So you need those, but that's too vague. You need to know how much of those things as well, because obviously as a disease becomes more severe and more developed, then you need more healthcare resource use. And so that's where you define this quantity in this column here. So we're saying that on average, for stage 1 CKD patients, there's about 11.3 GP visits per year. So almost once a month. So building your care pathway is essentially putting together the building blocks from the first step. What are the activities? And then multiplying them by the frequency that's required. So that's healthcare resource use data. And I've copied that, same process for all the various stages of CKD, including the various treatment modalities. And the next step after that is to scale it. So in this case, I've only did it per patient per year. So the next thing that I want to do is to scale it up to a treatment population. So I move on to the next step, which is the populations here. And you can see we've already got a population made up. It's called the treatment population, the treated population. If I look at this in depth, then you can see that it includes all of the care pathways that I built in the last step. And I've also defined the patient population in each of those pathways. So stage 5 at-home hemodialysis has 1,378 patients per year. Stage 3 has about 1.9 million patients per year. So that's by far the largest population. So this is how you can scale it up. Again, when you're making your population, it's similar to the last step, to make your population, you add together the various care pathways that might exist in that population, and then you multiply that by the number of patients that exist in that care pathway in a certain time frame.
Can I just ask, whilst you're on this, so you've said that there's sort of 1.6 million in, 1.9 million in stage 3. This could be applied at a GP practice level of 10,000 patients, or a hospital level, which might be 100,000 patients, or a regional level, which might be 20 million patients, or a whole country level. And so these figures are, you can change these figures depending on what size of population you're studying at the time. Is that right?
Exactly. So, as you say, from the beginning, one of the main design tenets of CARESA was to be flexible. So I'm saying treated population here as a national population, but you're right, it could be a ward population. And obviously in that case, the numbers would be a lot lower, but then the model would work just the same. It would just be multiplied by less. Likewise, in the previous step where I built up my care pathway, then you can imagine you can build your care pathway up out of any building blocks, and you can define any building blocks as well. So it doesn't, I'm using kidney disease in this case, but if you're interested in, say, a cardiac care pathway, then you can put cardiac specific healthcare activities in and add them together to create the care pathway as well.
So if, for example, I wanted a care pathway to include a cardiac rehab, so post-heart attack, people go to a group session where they are getting education and activity and exercise and advice and all the rest of it, I can model what that would look like for my setting and then apply it to the population. So I can add a building block of my very own based upon my hospital or my service. Is that right?
Yes, exactly. Exactly. That is most likely the largest bottleneck, though, is having your own data on that. So having your own data on sort of a cardiac rehab follow-up in terms of environmental impact is where the data is lacking at the moment. So, and I'd say that's probably too much of a technical question to get into in much detail in this call here. But obviously there are ways around it. You can generate your own data, you can use proxies and so on. But by and large, that's the data that is the toughest to come by. But you're exactly right. Whatever your care pathway is, wherever it is, and whatever skill you want to do, you control the data inputs, so you can build it however you like.
And just on that point, Gregor, there was a question around what is environmental data. So maybe I can just briefly give an explanation if you can go back to our environmental library, what we mean by environmental data here. So the building blocks of a care pathway is based on interactions or treatments or imaging or lab tests, whatever is relevant for your care pathway. Currently, the environmental impact that I was talking about, things like what's the carbon footprint or water footprint of a GP visit or an ED stay, ED visit or hospital stay. What's underpinning that data depends a little bit about what methodology was used to generate it. The Sustainable Healthcare Coalition has a guidance around how you pull these building blocks together. Theirs is a top-down methodology. So essentially, you quantify the, say, greenhouse gas emissions at the institutional level, accounting for all things that contribute to carbon. So that would be things like your energy, your lighting, ACs, anything heating. It will be all the consumables, all the equipment. It will be staff and staff travel. It will be medications, anesthetic gases, etc. And so you pull that footprint together for the entire institutional context, and then you slim it down to the department using things like area of the department, so floor areas, and then down to a visit level using your interactions in that institution over a period of time, like a year. And that's how you get down to the visit level or interaction level of a carbon footprint, say. That's the top down. That's what the SHC sort of builds their methodology around. You can also modulate bottom up, which was done in some of the data that we're looking at now, which is saying, okay, let's assume I have a primary care clinic and the average floor area of that room, examination room is going to be 12 square meters. This is how much energy I might need to heat it, light it, this is how many staff is going to be in it, this is the equipment and consumables it's going to be in, and you modulate essentially bottom up. And you need to use sort of conversion factors to convert your actual components like energy use and consumables into an environmental footprint. And that's what we see in these building blocks. So when Gregor clicked on one and there was a lot of components underneath, those are the components kind of driving that building blocks. I hope that sort of made it a little bit clearer. And when we think about treatments, obviously that's life cycle assessment data on individual medicines, for which there is already a standard published, the PASS 2090 standard. But for environmental impact data of interaction and visits, we don't yet have a standard, and the SHD guidance is the closest we have to one.
Fab. Gregor, I think that you were going to take the building blocks and you've built them into a care pathway, and we're then going to show what happens when you apply it to a population level.
Yes, thank you. Yeah, thank you for the summary. I was about to do that myself. Yeah. So we've got the population. We've put all the care pathways that are needed in that population. I mean, sometimes you're only interested in one pathway, right? One at a time. And then you define how many patients are in it. And really, that's the step. That's the population scaling step. At this point, if what I was setting out to do was understand what is the environmental impact of CKD care pathways in my treated population, well, then I can just go straight to the results because I'm just looking at the baseline. So this is what the results page looks like. The top of it gives you a sort of plain language readout. Now, in this case, in this model, I've not used any waste or water data. It's just been CO2 equivalent. So it gives me a readout and it gives me a comparison there. When I scroll down, though, then it starts to give me more granular visualized data on where is this 1.8 billion kilograms of CO2 coming from? What's driving this? So here you can see, well, there's one bar that's in the care pathways that's having a particular impact. And if we scroll over, we see it's stage 3. And if you remember, that might make sense given that the stage 3 population was by far the largest. There was, almost 2 million people in that population. If I go to the environmental input tab here, then you can also see of the building blocks that make up our care pathways, which ones are it that are driving the environmental impact primarily. And the large green one here is hospitalization, followed up by patient travel afterwards. So this is how you can start to hotspot things and where you can see what are the primary drivers of the environmental impact in my care pathways. If we scroll down a little bit, you can see a table of results here as well. It's the same data from the graph. It just shows you in tabular form. So you can see it's sort of the various care pathways and what their impact is, and then the various environmental inputs in each of these care pathways as well. For further hotspotting, you can use the heat map. So, I mean, no prizes for guessing what the bright red one is. It's hospitalization, but it also tells you that specifically it's hospitalization in stage 3. So it's the stage 3 care pathway hospitalization building block that's driving a lot of the environmental impact. Likewise, the tree map's really useful for seeing where hotspots are. So the size of the square, the proportion of the square is how much the contribution is. So at the population level, the first one, there's only one population, so it's the whole square. But then at the care pathway level, you can see that stage 3 is by far the largest contributor. We can click further in there and we can see that in there, hospitalization is the largest driver of it. And then, as Katarina said, you can dive one layer deeper and see in hospitalization, what are the subcomponents of hospitalization that are driving its own environmental impact. So in this case, natural gas mix, electricity mix, plastic mix, and so on. So there's tools in here to report the overall model results as well as dig down into the various hotspots and what's really driving the environmental impact. Because you can see here, there's dozens and dozens of data points that are coming together, but really hospitalization in stage 3 is really driving it all. So as I said, Matt, if you wanted to just understand the baseline, what's happening right now, then you're done, which is for a lot of people more data than they have to begin with. You just want to understand what the baseline is. But if you wanted to make changes to it, so if you wanted to make changes to your care pathway, if you wanted to optimize them, if you wanted to look to see what effects early diagnosis would have, then I think this is the real strength of CARESA, which is that you can model these changes and see what the environmental impact of those changes are. So if you're happy, I'll move on to that now quickly before we come off.
No, please do. I think that this for me was, because I know that when I was part of the training or came to a full day session, it was this: what is the change that we can make and what is the impact on patients going to be? that for me was the critical bit. It's great knowing that patients ending up in hospital is the biggest carbon footprint at stage 3, but actually we need to keep them at stage 2. And if we can start to model what would those interventions look like to prevent deterioration of disease, how's that going to play out? So having some scenarios and modeling those is really, really helpful. So yes, please press on.
So I've got 2 scenarios that I put here. Building the intervention, the scenario in this tab here in the top right is the most sort of technically complex part of the model. Is maybe not surprising. So I'm not going to go into too much detail about it. I'll just explain what I've done. And, obviously after the call, I'm very happy to have any follow-ups for any more technical questions. But what I wanted to show was early diagnosis. So in my sort of hypothetical change to the care pathway, I wanted to ask, okay, if we introduced a way to diagnose some aspect of CKD early to prevent progression to later stages, what would the environmental impact of that be? Bearing in mind that the intervention itself would have environmental impact, right? If you're doing early diagnosis, that means you're doing some sort of activity, whether it's healthcare or a device or something like that. So in that case, I have my intervention here. I've just called it early diagnosis. Again, it's just very simple for this demonstration. And I have 2 scenarios in this tab here that I've used. I've got early diagnosis, and the early diagnosis is to prevent the progression to stage 5 specifically. So it's really just looking at preventing progression from 4 to 5. And I have another scenario which looked at exactly like what you've suggested, Matt, which is just, it is generally fortuitous, is early diagnosis to prevent progression to stage 3. And so I wanted to show these things. The way that the scenario modeling works in CARESA is that you essentially move patients from one population or one pathway to another. So we know that if I go back to the populations tab quickly, we know that in our population there are 1.9 million patients in stage 3. We know that there are 1,000 or so patients in most of the stage 5 treatment modalities. So the way that we model the scenario is we move the patient numbers. So if instead of having 1,100 in conservative care stage 4, what if we applied this intervention of early diagnosis and a certain percentage of the patients in here were successfully arrested in stage 4 instead? What would the environmental impact of that be? And we can see the results of what that is in the results with intervention tab here. So my population is a treated one, which is our only one. And the scenario I'm going to select is early diagnosis. And again, the idea of this is to prevent progression to stage 5. We can see, first of all, the results page is a bit different because it's inherently comparative. You're comparing it to the baseline that we did first. So we can see that in this case, there is a saving of about 34 million kilograms of CO2. You can see the same stacked bar charts as before. And the result of this is basically that the impact from stage 5 has been reduced because there's less patients in there and they've been moved to a less environmentally impactful state, which is stage 4 or stage 3. Obviously, on the flip side of that, it's also probably a better state to be in for the patient clinically because they're not in stage 5, they're not in end stage. And the rest of the results pages is really just the same. It's just comparative, so you can see the difference between the two. And the other one that I did, again, is the early diagnosis to prevent stage 3. It also has, but you can see in this case, it has a greater saving, unsurprisingly. And that's because the population in stage 3 is so much bigger that any change in the population numbers is proportionally larger as well. And I think that's pretty much it for now. I appreciate there's probably questions about this, how it works, the technical side and so on. So I'm very happy to answer them. But Matt, was there anything else that you wanted me to show here, or Katarina?
For me, I think that this is looking through a window. This is not a full training session. This isn't going into all of the details about how to build the individual building blocks. So for me, I think it's for the audience to say, has this given you enough of an insight? Has this whetted your appetite to be able to say, yes, this is the sort of thing I could see being quite useful? I know that, for example, from a respiratory perspective, that as interventions occur, so people are changed from one therapy to MAP therapy or something else, that actually we know to some extent what the reduction in hospitalisation, the improvement in symptoms are, the same for renal disease, the same for cardiac disease. So actually being able to build upon these things and model those scenarios is, for me, a really important thing. But it's really about whether those who are listening are whether you've had enough of an insight. Katerina.
Yeah, I just noticed we have a couple of questions. So I think there's now 3 questions in the Q&A, and I think they're quite well positioned to.
I think answer the questions, and then later on I might be able to get some more questions in. But I think that we go through the questions in the Q&A next. Do you want to answer? Do you want to read the first one and then answer it, or do you want me to read it?
Yeah, I think I will start a little bit backwards. But there is, and Gregor, maybe you can have a stab, and then I can contribute around the reliability and applicability of publicly available data, and sort of the assumption that what is in the public domain is robust, and if it's not, whether we're just multiplying up, the errors through the whole model.
Yeah, so let me start on the geographic questions then, which I think is a bit of a simpler one, which is that, yes, the most data we have are from certain sort of geographic hotspots, the UK being one of them. And if you did want, you're talking about transferability of the tool there. For the tool to be useful somewhere, you need relevant data. That doesn't necessarily mean you need your own data set for your own country or your own region, but you do need suitable data to use as a proxy, if not. So that's the limiting factor. It's not really a limiting factor of the tool, because the tool can handle whatever data goes into it. It's a limiting factor of just the data availability right now. And I hope that answers the last question that we got in there as well from the anonymous attendee. Yes. And if that's clear, then shall I hand over to you, Katarina, to talk about the reliability and applicability?
Yeah, I'm happy to take that. So I think the question is, how do we know sort of this is robust data on the platform in the public library? And as I mentioned before, there isn't currently sort of a standard that we all follow in the sector, like what we have for the medicines LTCA. So what we've decided to do, and this is sort of something we can discuss and debate, is we've decided to put all the publicly available data on the platform and not sort of make judgment call about what to include or exclude. What we wanted to do was to be as transparent as possible about what's underpinning that data. So you saw the referencing there. What we will layer with is also the methodology and the standards that are being followed as part of that data generation. That will be in the next update, to make it very clear to users where this data is coming from and how it was generated, so they can make the judgment call whether to use it or not to use it. Maybe they want to use their own data then or generate their own data. So currently we're not policing the library in that sense. If there is a standard agreed in the sector, then we can start labeling things accordingly. So for example, when we pull medicines data on top of the platform, we can label it with past 2090 or 2050, whatever it is, so people can search for it and then pick if they want to use data that's more adherent to the current methodological standard. I hope that answers that question. And I think there was a question around transferability of the tool in sort of data poor versus maybe data rich settings. And I think it's a great question. Like Gregor mentioned, we are sort of generally in a data poor state when it comes to these type of building block data for care interaction. So it's kind of almost like a call to action to all of us on this call and beyond to really think about, can we start generating more of the data that could feed tools like CARESA to enable wider sort of applicability of this type of methodology and more data generation around care pathway, environmental impact for various disease areas. Coming back to that principle that as we optimize care, we're also delivering on the sustainability goals. What we're thinking from a CARESA development perspective is whether we can link up with some of the databases that are being developed with those submodule components, and thinking like what was just launched around the Lancet Med Zero initiatives, whether they can be that original data pool that people can use to basically build their modules on the platform and then pull them through the CARESA model, which will be a full end-to-end solution. Then you have everything in one place. That will be sort of the wider ambition, and that's something we're exploring as part of the team. But we'd love to hear kind of other people's feedback if they see other databases or solutions that could tackle this. And also about publications. Given how much we've already covered today, CARESA is actually quite young. So it was conceptualized about 2 years ago, and it's been in beta testing for about a year. We've had some people use it in various different ways. So for example, the Sentinel Quality Improvement Program up in Hull that looks at integration of guideline-directed care for asthma, and has quantified some of their carbon footprint from a medicine perspective, used CARESA as a database for their wider care pathway environmental impact assessment. So we see some of those data being used, but not yet published. And in other contexts, like in the Nordics, we've seen CARESA being leveraged as part of a wider collaborative context. So basically a catalyst for bringing system stakeholders together to think about decarbonization of healthcare. So it's been used currently, I think, more than just a tool as people are trying to get their heads around how it works, but also as something of a collaborative catalyst and infrastructure assets, essentially. I think that helps answer some of the questions that we've now.
I think I might chip in as well. I think that one of the things which from a healthcare or from a clinician's perspective, we always want certainty. We always want an absolute number, and this is the number that we can always use. And I think when it comes to environmental impact, there's always a range of answers. It's a bit like, one number, the average height of a person or the average weight of a person doesn't tell us well, not error bars, but the range of the data, that we're going to get some people who are much taller or much shorter or much fatter or much thinner. And I think that when it comes to carbon footprinting or environmental impacts, there is that degree of uncertainty which healthcare professionals are not always comfortable with. We do deal with uncertainty, but we don't like it very much because it's a lot easier if it's either yes or no. So I think that when it comes to whether it be the Lancet Med Zero tool, whether it be CARESA, whether it be a whole host of other things, that there is inherent uncertainty. And unless we do a full life cycle assessment for every item, every procedure, every care pathway, we're always going to miss some of the nuance. So for me, I think that, have we got more data now than we had 5 or 10 years ago? Absolutely. Have we got all of the data that would satisfy and quench our thirst? Absolutely not. Will we have more in 5 or 10 years? Absolutely yes. And I think that being able to take part and add data or add units of a part of the care pathway within this actually helps. It means that more of us get more robust at being able to understand the nuances and the range and the uncertainty that goes along with it. So for example, Centre for Sustainable Healthcare run green team competitions where we help, aid, assist, encourage healthcare staff to look at the care that's being delivered and to be able to make changes. If people do those sorts of activities, so that they're measuring their environmental impact, and then they're wanting to make an intervention, would this sort of tool be quite useful for them to be able to have their own building blocks that are not necessarily publicly available? Other people can't necessarily use them because this is my care pathway for my hospital, for my speciality that I've measured, but actually they could use that within their own calculations within the tool. Is that an option to be able to add them? And then the subsequent question that I'm going to then ask Gregor is, if they did feel that their data was robust and followed the guidance that is available, could they then make that publicly available and have certain labels on it so that people like Matt Welbury-Smith can say, I see the number, I see the answer that you've got for your trust or for your department or for your care pathway, but ours is a little bit different. So I'm going to amend it, or I think we've got a bigger travel footprint, or whatever it is. So two questions in one there.
Yeah. So first of all, absolutely, you can make your own. You can put your own data. You may have seen when I was showing the model and in the library, there was the grey data, which is the public data that's in the library. And then there's light blue data, and that's my own personal data. So no one else can see that. No one else can use that. It's confidential, just for me. So if you have your own data, whether you've done your own studies or you're taking some of the public data and copying it and just making some educated edits to it to make some, best guess, as you say, then you can absolutely do that. If you did do a study and you wanted to share the data into the public library, right now, there isn't really a sophisticated data submission portal. That is on the docket for launch, but really it just comes to us at the team and we review it, and then, it'll most likely go up if it's published. Because as Karina said, we're more keen to put all the data that's available out there with full transparency on the methodology and the guidance that was used to generate it, and then allow the users to make their own decision on which data they want to use.
Yeah, and to build a little bit on that, when we conceptualized CARESA 2 years ago, we knew that at some point we would run into a resource gap where it will become really difficult to keep the library updated ourselves, because it's just not probably enough hours in the day to do that. So a crowdsourcing mechanism was always part of what we were thinking, to allow basically all of us to be able to input into that library, within certain quality checks, to ensuring that the methodology is robust. So very much it is, like Gregor said, on the development docket, to make sure we allow for that mechanism, because more and more of this data will become available, and it will be hard for us as a team, given we're very small, to keep up with all of it.
Brilliant. I'm going to go back to the Q&A, and I'm going to ask you both some questions. So has the tool been used outside of England? So are there people elsewhere, whether that be the rest of the UK or wider, who have used the tool with sort of care pathways beyond, in inverted commas, just the NHS?
Yeah, so that also, I think, comes back a little bit around the beta testing. So when we open it for beta testing, we open it to anyone, regardless of which, geography they were in. So we have beta testers, I think over sort of 300 beta testers currently on the platform across sort of 20 to 25 different countries. That includes both private sector and public sector, so people in different health systems, clinical positions, but also people sitting in our peer companies as part of the testing down within the Sustainable Market Initiative and the Stable Healthcare Coalition. So there's a wide variety of users. And we have intentions from a lot of those stakeholders to use CARESA when their own data becomes available. So again, coming against that data issues. So some of them have used the presence of CARESA as a way to motivate their institutions to drive generation of these type of data, building block data. And once they have that data, they pretty much intend to use CARESA to pull through and calculate their full care pathway model.
I think that probably touches on the next question from Justin, which says, since the surgical pathway can vary depending on hospital protocols, material use, device reuse practices, anaesthetic choice, etc., does the user need to build the pathway model manually before use, or does the tool provide predefined templates that can be adapted to each hospital context? I think that you've probably answered most of that question.
Yeah, but I mean, it's a really great question, and that's something we've actually also discussed as a team. CARESA is inherently a user-driven model, so even though we've provided a library, because a lot of us sitting in sort of healthcare roles or system roles aren't really environmental modelers, so that is what we need as a sort of a crutch to get into this type of modeling. But the idea was that the user will bring their care pathway data, because ultimately, the best the patient population you study or take care of, and bring that data to the platform to model the care pathway. that hasn't sort of prevented the discussion of what, should we share some templating so people who are totally new to this can sort of springboard off of that. And there is currently the CKD case study that's been published is on the platform as a template. And we're happy to build up the templating if that's what the user sort of requests, I think will be helpful.
Brilliant. Gregor, I'm going to ask you the next one. And I'm going to, this is from Scosters, I'm going to add a little bit of my own question and I'm going to expand it. If you won the lottery tomorrow and you've now got 10 million quid, would you want to include other sustainability dimensions such as economic, social impact, and even things like pharmaceutical pollution in waterways, plastic use, etc.? And if yes, how would that be produced? You don't have to win the lottery just to do that. You might just be very well paid, I don't know. But is there an interest in including more sustainability dimensions in the tool?
So no doubt in that. I mean, I can give my opinions, but I don't own the tool, right? So that's really up to Katarina, what she wants in it. But I can give my thoughts, which is that in terms of sustainability dimensions, yes. I mean, if you look at something like recipe, the recipe guidelines and the various sustainability dimensions in that, the way that the model builds up the impact, it could do that for any of these dimensions if you had that data. So if you're interested in ecotoxicity, or if you're interested in air quality or parts per million, that sort of fine particulate matter, then it would still add and multiply all these components together to create a result at the end. It's just we are bound by the three that we have on screen at the moment, which is carbon, water, and waste. So if I could wave a magic wand and have something that was like a drop down that let you select something, a sustainability dimension from a list, just so it showed up on the page, I think that would be great. Economic, though, is more complicated because there's already well-defined methodologies for working out, sort of the economic impact of care pathways and so on. And I'd probably give that over to you, Katarina, to talk about that if you'd like to.
Yeah, this is a question we get quite often in terms of, it wouldn't be really helpful to have multiple dimensions that you could pull into one tool. But we also get the feedback, well, it's quite nice that it's so focused on the environmental part and it's not all these other complexities. So I don't think we've landed on a position yet. I think we still need a little bit more time and probably feedback from the wider user base and health sector stakeholders to see, is that something useful? Is it really helpful to have something that purely focuses on the environmental aspects without sort of bringing other complexities into the picture, given also in terms of pulling all of those dimensions, still quite unknown methodology and haven't been properly developed.
It's always that tricky bit, isn't it, between having an all-singing, all-dancing tool that does absolutely everything for everybody everywhere and having something which is, really good at, not just doing one thing, but in this case, measuring the environmental impact of care pathways rather than everything. So a quick fire question before I'm going to ask you both for a take-home message. How can people get involved and what people's next steps are? And Ollie, I'll ask you to put the Mentimeter word cloud up in a second. But before I do that, I'm just going to ask, is the tool free to use and how is it sustained financially? Whether either of you have got an answer to that one, and then I'll ask you for your take-home thoughts.
Yeah, I can take that. Yes, the tool has always been intended to be not sort of non-commercial, so it is open and freely available. And once we publicly launch, you can just Google and find it. Currently, you have to still go through us because it's in beta testing, but anyone can get onto the platform, and we'll show up a slide how you do that and how you get it sort of ask for access. How is it? We funded it as AstraZeneca in terms of its development and partially through the Sustainable Market Initiative. The plan, and has been from the beginning, is that CARESA will be handed over to a public and or academic institution to be run in the long term, and we are starting to work on that transition planning this year. So if anyone is very interested in taking it on or supporting it, feel free to reach out to us.
I'm sure we can put your email or your bank details in the chat. So Ollie, if you're happy to put on the word cloud Mentimeter, and I'm going to ask both Gregor and then Katarina, what would you what can you see, or how could people do things next? What's the next step that people could take? Gregor first. And if people in the audience scan the code or go onto Mentimeter, put in the code and put in what you're going to do next, that would be great. Gregor.
Okay, I'll go very quickly because I know Katarina's input is going to be much more valuable than mine on this particular question. I would just say you can get access to the tool right away. I can see some people have already emailed, which is great. And I would say to get started, don't let perfection be the enemy of good. You can start building care pathways very quickly using stuff in the public library. The data doesn't have to be perfect, doesn't necessarily have to be from your country, but it'll at least get you familiar with the building the care pathways and scaling them up in the tool.
Fantastic. Katarina.
Yeah, just to build a little bit on that, is just thinking of the tool sort of more than the tool itself. So how can it help drive conversation, either by the data you do generate, whether it's some preliminary data, but how can it help you drive the wider conversations around healthcare sustainability within your institutions? What more can you do in generating that data that can be used by a broader audience within our sector? So I would think about how to leverage the tool itself beyond the modeling it can do to drive collaboration either within your institutions or across different institutions.
Fabulous. In the chat is being put the expressions of interest, the email address. Do either of you know when the tool might be launched, what month or what part of the year it might be? And if so, how could people find out about the launch?
So we're planning launch currently for September, and we'll intend to sort of have a social media presence, and we're happy to also work with the CSH to maybe have you post on it as well, so to make it widely available, that this is now sort of accessible publicly and anyone can register and gain access to the tool.
Brilliant. So people, what they're going to do next, I think most are going to give it a go, access the tool, have a try. One person says that they're going to have lunch. That wasn't me, I promise, but it is 1 o'clock. We did say we would finish at 1. So I'm going to say thank you very much to both Gregor and Katarina. Say a huge thanks to Ollie, who's been working in the background. And I think we should all go and have lunch and have a think about what we're going to be doing next. So thanks to everybody who has attended.